do want to say a few words to psychologists. We are getting many psychologists in the community here who need credits for their licensure now. And I just want to remind them to make sure they sign in on the sign-in sheet as they come into the lobby. Make sure you leave a clear address that's readable and where mail will get to you, including your certificates from the American Psychological Association. Also, you need to fill out an evaluation and make sure you sign that as well. A couple times this year we've had a few substitute programs, and when we do that, we will try to give credit for those if possible. Occasionally, we don't have a videotape that's appropriate, or the substitute speaker doesn't talk on the proper topic, and we may not always be able to give credit. So if you're looking for licensure with these credits, it would be good to attend a few extra programs just in case we can't always give credit for them. Okay, now to get to the subject at hand today, it's my pleasure to introduce Dr. Martin McGurrin. Dr. McGurrin received his Ph.D. in social psychology from Temple University in 1971. Since 1986, he's been a senior research scientist, and recently he also became a clinical associate professor at the Department of Psychiatry at the University of Pennsylvania. And he works with the section on public psychiatry and mental health services. Previously, Dr. McGurrin was director of planning, evaluation, and data management at the Philadelphia office of mental health and mental retardation. And in fact, in the early 1970s, he also worked at a state hospital, so he is familiar with our patient population here as well. I'm pleased to introduce him and welcome him here today for his talk on suicide.
Thank you. Good morning. I'm pleased to be able to be here again to speak with you. I was here in 1990 discussing the topic of suicide, and I moved as quickly as I could through the program, trying to cover all the materials that I had brought with me, and actually neglected a number of points in my opinion. And after the presentation, when I spoke with Edith Cron, she said it seemed like you had enough for 2 sessions instead of 1, and I agreed. And so this time, my visit with you to talk about the topic of suicide will be done for 2 hours this week, from 10 until 12, and 2 hours next week from 10 until 12. And as we get started, I'd like to explain to you the general organization of this presentation, so we're clear on that from the start. Today, I'd like to spend most of the time giving appropriate attention to details on what I would call foundational conceptual and theoretical aspects of the subject of suicide. We use the term professionally and in general discussion as if it were a rather simple phenomenon, like many terms that we use, truth, justice, love, honesty, courage, and it's anything but a simple, homogeneous, one-dimensional phenomenon. In fact, it has very different meanings in different settings. It has had very different meanings in different periods of history and in different cultures. And the way in which it's studied and analyzed often creates a different image of suicide depending on the methods that are used in studying and analyzing the phenomenon. The one thing that I think we can certainly agree on, and has been generally agreed on at all times, is that suicide is the word that we use, we reserve to talk about a behavior that seems to stand in a class by itself because it is the behavior that involves an individual intentionally ending their life. It is the deliberate, intentional act of self-destruction. Now, that in itself may seem so obvious, since we're familiar with the term, that it doesn't seem worth stopping to think and talk about. But what I would like to do today is to help all of us break a few mindsets that we fall into as we use language and ideas on a routine basis, and look at every aspect of suicide as if it were strange and unusual and something that we didn't really understand very much about or were not very familiar with, so that we're looking at it as if it's a totally new phenomenon, a totally new issue to us as we discuss the concept. For example, one reason why it is remarkable in a way that people do end their own lives is because in almost all other branches of behavioral science and biology for at least the last 100 years, there have been repeated emphasis on concepts like life force, motivation to survive. One looks at the remarkable ways in which organisms of all types struggle to overcome environmental adversity, to stay alive, endure discomfort and inconvenience simply to prolong their life. At points where some of us would question ourselves whether we would really want to continue to persist in living because of the extreme discomfort that the person is experiencing. And there are people who defy the best medical judgment in terms of when a terminal illness will discontinue their life by living past that point, and in some cases having remarkable spontaneous recovery. So that on the one hand, there's a great deal of emphasis, there is data, there's a whole way of looking at the living organism, whether it's an amoeba, a bivalve clam, or a human being, that says once a life begins as a biochemical and behavioral process, there's a tremendous force to keep it continuing in that vein until it absolutely is no longer able to support itself, because dying cells, old cells, can't be replaced adequately by new cells, that you just wear out eventually. On the other hand, we do observe the fact that in human beings, and it really is a phenomenon limited to human beings as far as anyone has ever been able to document, this remarkable tendency for people to end their lives. And sometimes they do it when they're very young. It is less common under 12 years of age than at any other point in life, but it is not unheard of. Young children, preschoolers, but certainly elementary age children, elementary school age children have a rate of suicide. They do kill themselves. Among the adolescent years and young adult years, suicide peaks, and it has a startling rate of occurrence at the point when many people are seeing life beginning to become challenging, exciting, experiencing the thrill of independence and self-definition. Others, as I say, at a startling rate, are making plans to abruptly end their life. It occurs throughout adulthood, and again, rises slightly above the adult average rate as people reach old age. Of course, that's a difficult term to define, but certainly by the time people have reached their mid to late 60s, and this is often associated with retirement, discontinuation of life activities. I know there are several people in the audience, two of them I've been introduced to this morning, who who retire and then become reemployed again, and then retire and become reemployed again, and they're, in a sense, the antithesis of the person who is dropping out of life. They're staying involved very actively. But for the majority of people, certainly in Western European societies, 65 has come to arbitrarily mark a point where our productive life, our work life, our career life is over, and many, many people are not prepared for the experience of life after work. It doesn't even occur to them to think about what that's going to mean, and it can be an extremely depressing and disconcerting experience for them. So some people feel it is no surprise that when you combine this abrupt change in life schedule with the increase in incidence of different types of physical pathology that are associated with aging, that the risk of self-destruction might increase again. In any case, the point is, it happens throughout the life cycle of the human being, and it seems to be a uniquely human activity, whether you think of it biopsychologically or social psychologically or even spiritually, and that's a dimension that certainly needs to be considered. My training and credentials don't qualify me to comment on that aspect of it too much, but it certainly is an issue that can be considered from that perspective as well. What we will be doing today then is looking at this phenomenon and asking ourselves not just what is the cause of suicide in a mechanical Newtonian physics sense of cause and effect, push and movement type of logic, but more so in a biopsychological sense. What's the meaning of suicide in general, and what's the meaning of suicide for an individual case, whether it's an attempted suicide or a completed suicide? Because if you simply look at the behavior externally in a very mechanical cause and effect type of manner, you, at least by my own view and many others, miss about 90% of what's relevant about the phenomenon. Meaning is as relevant and as much a part of the issue of cause in the area of suicide as any other more objective and physical characteristics. So we are going to be spending time today looking at the meaning of suicide as a way of understanding the cause of suicide and seeing how this meaning fits into all the other sets of meanings that we embrace as we live out our lives as human beings, and in particular, that you as persons who are involved in the care and treatment of seriously and persistently mentally ill people bring to the treatment setting, the treatment environment, in your effort to reduce their suffering and return them to a normal, as functional and nearly normal a level as is possible for them given their condition. Let's begin, and I hope I don't drive the cameraman crazy moving back and forth here. If this isn't the best way to do it, just let me know. Let's begin then by giving ourselves a simple 2x2 table model to start organizing our thoughts about suicide. A fourfold classification of suicide. One of the repeated aspects of all analysis on suicide is the distinction between threatened suicide or suicidal ideation, attempted suicide, where it goes beyond ideation and threat and into an action with perhaps even a fairly well-defined plan, and completed suicide, which is the only certain way to establish that the intention was connected to the consequence. So when we talk about these different combinations, what we're mainly interested in are the attempted suicides that succeed, or in the terminology of epidemiology, true positives, valid suicides. Even there, a judgment is involved sometimes, but that's where the truest count of true suicides would occur. However, there are also people who do not attempt suicide or don't appear to be attempting suicide, but succeed. These are people who, through reckless and perhaps unconsciously self-destructive behavior, commit suicide. Now, this is why the issue of meaning is so critical, and the psychological aspect of it is so critical. You'll see very soon when we look at some of the comparative data on causes of death in the United States that a major cause of death is for all age levels, but among adults and young adults, is death by accident, trauma and accident, and particularly death by auto accident. And I'm certain, as most people are who study suicide, that there are a fair number of true positive suicides that are not officially classified for purposes of vital statistics and death report data that fall into what would be called a not attempted suicide that succeeded, or someone who became reckless and unconsciously self-destructive in an automobile or in other situations, but particularly in an automobile, and especially if they're influenced simultaneously by some type of mind-altering substance like alcohol or drugs. And we have the false negative, the person who attempts suicide but doesn't succeed, and we don't count them as a suicide until they succeed. And one of the things we'll note is that the single best predictor of a true positive is the number of times somebody is involved in a false negative. That each time a person attempts suicide, the risk of succeeding, the probability of repeating increases, and the risk of succeeding increases tremendously. So that the single most important information that we could gather about a person coming into a hospital or into any treatment setting, and if we don't find this out, we're definitely remiss in the process, is have they ever made a threat and a convincing attempt to commit suicide at any point in their life? That's an absolutely critical piece of information for a client record. And it's amazing how many times I've been involved in developing instruments that people can use in community settings to do early screenings for people coming into community mental health centers and other treatment settings. It's amazing how many of the intake workers feel uncomfortable inquiring about that, and if it doesn't come up, they don't force the issue and bring it up. It's an indication, again, of how we feel about suicide. It's an embarrassing topic to ask another human being, have you ever thought about killing yourself, or have you ever attempted to kill yourself, is regarded as being very embarrassing and inappropriate, even to professionals. So I can't stress the importance enough of being realistic and professionally responsible and finding out this piece of information. And finally, we have the true negative, the non-suicidal proportion of the population, which fortunately represents the vast majority of the population, but nonetheless is really only a kind of logical or mathematical category, because at any time out of that particular cell may come the next attempted suicide or successful suicide. We don't carry around signs most of the time advertising the fact that we're a candidate for suicide at some later point in our life, and so one never really knows in the general population when things will change and the risk of suicide for the person will increase rapidly. All right? Now, we've acknowledged that this is not a simple concept. and one to be regarded naively. Where does it stand in terms of causes of death? Where does it stand, looking at it from a prevention and an intervention aspect? Where does it fit in mortality patterns, at least in the population in the United States? By the way, I want to interject here. I recognize that for some of you who were here in 1990, some of this is a bit of a replay, and I couldn't think of any way to avoid doing it without covering some of these topics twice. So bear with me, and I assure you that by the end of this session, and certainly all of next session, we will be covering totally new material, and it will have a great deal of practical, hands-on kind of value to it. But on the other hand, I recognize that we wouldn't have 100% replication or same audience, and I feel you have to approach the hands-on aspect of it from a broader conceptual base, and I really didn't get the time to make some of the observations about some of this material that I wanted to the first time around anyway. But I am sensitive to this, and I recognize that you are recognizing, if you were here before, you've seen some of these tables, or we've talked about some of these issues. All right, again, let's ask ourselves, if suicide is an important issue, is it an important issue because it is a particularly significant cause of death, mortality factor in a population? Every year, a certain percentage of a population experiences death. Every cohort that's born into a population has a death rate associated with it over time. And one of the things that we do for very good reasons as human beings is to keep track of how many of us die every year and what we die from, what causes death, and are we able to make any changes in those rates? Because that's certainly a major objective of medical and biological sciences, as well as increasingly behavioral sciences. Well, for some time now, continuing into the present, the major cause of death, as many of you may know, at a rate of almost 170 persons per 100,000, is caused by diseases of the heart. And there are lots of reasons for that. The second most frequent cause of death, 133 per 100,000, are malignant neoplasms in various forms of what people in common parlance refer to as cancer. Third cause of death, accidents and adverse effects of motor vehicle accidents. And that's, in one report that I'm looking at here, most recent data, almost 20 per 100,000. It follows a trend, a pattern from 1975 through to the early 1990s of being around 19 to 20 per 100,000. So it's a drop down considerably from these two other types of death, and it's not a cause of death that's primarily preventable by medical activity. It's secondarily treated by medical activity, but that's not what causes people to have motor vehicle accidents. Then we drop down to chronic obstructive pulmonary disease, pneumonia and influenza is 6, diabetes mellitus is 7th, and finally we get to suicide as the 8th most frequent cause of death. But we're talking about something that's occurring only about 12 times per 100,000 persons. So that in terms of the magnitude of people dying because of suicide, we can hardly justify the great concern and attention that's been given to it. And we're looking at how does it become a topic of concern to us. It's not because it ranks very, very high in the list of causes of death. So we'll have to look elsewhere for the meaning. And it's also interesting to note, as you'll see on the table, on the chart on the screen, that while Americans seem to do a fairly decent job of putting their lives at risk by driving around in automobiles, they are more likely to kill themselves, to cause their own death, than they are to kill someone else. Because homicide falls below suicide in causes of death. And this is an interesting aspect when you talk about the meaning of suicide. A number of the explanations that have been offered for the causes of suicide, internalized aggression, frustration, stress, unresolved hostility, anger, interpersonal conflict, could just as easily, in some respects, be resolved by committing homicide. In fact, it isn't self-evident why you wouldn't want to reduce the stress on yourself by ending somebody else's life rather than ending your own, internalizing it on you. So it creates a kind of an enigma. Why is it that here in the United States, in the general population, we tend to kill ourselves more often than we do kill other people? Well, what's also intriguing about it is that this isn't true for all subpopulations in our population. There are subpopulations where homicide is 3 to 4 times more frequent than suicide. And there are subpopulations where suicide's even more frequent than it is among the general population, and 30 to 40 times more likely than homicide. In fact, to pull in for a moment to consider state hospital environments and really many other institutional environments as well, including prisons, there's much more attention given, and as a former staff member, I understand this, there's much more attention given and has been given in the literature and in thinking about patient management to patient violence toward other patients and staff than has been given to the issue of patient suicide and patient or inmate in the case of prisons. The prison guards concerned about inmate A knifing inmate B on the way to the cafeteria, much less alert, trained, and concerned about whether inmate A manages to find a way to use even something like a towel, which doesn't give you a lot of extension for purposes of strangulation, but it's been done. Use a towel from the showers to strangle themselves, to commit suicide. So something about suicide-homicide relationship we probably want to talk about a little bit more. Institutional population rates, by the way, are 3 to 20 times higher than the general population. Prison population lockups have a rate, by a lockup I mean the first stage of being taken off the street by the police and just kind of thrown in a cell, a holding area, 279 per 100,000. I mean, think about that compared to heart disease and cancer. It dwarfs them. You take especially an adolescent who's 19 or 20 years old or a young adult, take them off the street on an offense, drunken DOD or possession of an illicit substance, put them in a lockup, and while it's nobody's intention, you suddenly increase that young person's risk of killing themselves astronomically. And it does happen. I know that I saw in the news recently there's a prison in Georgia where the inmate suicide rate has been startlingly high, and it received some attention on the news because in Georgia, it's viewed by one part of the population as being just poor prison practice, and another part of the population as being a form of institutional racism, because there are a fairly large number of Afro-Americans who have been included in the suicide count, but there have also been a good number of Caucasians involved in it as well. In any case, it doesn't generally strike people that this is a risk of putting somebody in a detention area, but it's a very important area to monitor and to prepare in such a way that people cannot kill themselves, because far too often young people are put in this situation, and the instantaneous guilt and confusion and shock of the experience is enough to drive them to this radical action. In the adolescent population, there are 10.2 suicides per 100,000, actually sometimes a little higher than that, and it's the third leading cause of death among 15 to 19-year-olds. Adolescent rates have doubled from 1961 to 1975 and tripled from 1956 to 1975. And they're kind of at a plateau right now, but they're still very, very high. One of the reasons why, one of the factors that seems to be involved, by the way, and I'm not saying this from a conservative or a moralistic point of view, just from a purely factual, statistical point of view, is that the increased abuse of substances by adolescents and young adults seems to be very closely related to suicide. About 75% of the late adolescent young adults who succeed in committing suicide, especially the ones who use what are called high lethality techniques, very lethal, a gun, jumping off a tall building, something of that sort, are usually found to have excessively high alcohol blood levels at the autopsy, or are known to have been drinking heavily before they committed suicide, or using some other kind of drug. So that these mind-altering substances that have an effect on inhibition have had an effect on teenage suicide rate almost certainly. Okay, now we've placed suicide within some reference of causes of death, and I've commented that as a cause of death itself for the total population, it is not a remarkably frequent cause of death, and consequently one would really question how much effort you would put into trying to reduce the risk, since every effort to reduce the risk, even and especially at a level of a treatment center like a state hospital, is going to involve cost and effort. And while one doesn't want to think that this should be an issue left up to accountants and business managers, the fact is, if you're going to monitor a patient for 48, 72 hours because they've made a serious suicide threat, and you use the most effective method available, which is just having somebody watch the person all of the time, you can sit down and calculate how much that's going to cost, and you have to carry it as one of the factors that you consider in how you approach and prevent a repeat of the suicide. Again, in terms of breaking mindsets and not looking at things in terms of stereotypes and sentimental attitudes, people can say, oh, well, there shouldn't be any cost too great to bear or to spend to prevent someone from committing suicide. You have to stop and check that out and think about it a little bit, and what the environment is, why the person may be attempting to commit suicide, what the liability is to the treatment personnel, the legal liability is to the treatment personnel and the institution, as well as something that we would be more emotional about the value of human life or the need to prevent suicide. If I sound a little caustic or cynical, it's only because I'm trying, again, to shake us out of the habits of thinking that we get into, in which on the one hand we express a great concern about preventing suicide, but when you turn around and watch what people are doing, their behavior doesn't always match up with their expressed sentiment and concern. So I don't think I'm really being that cynical. I'm just trying to sensitize us to how we think about this issue. It is a serious issue in a psychiatric inpatient setting for long-term care patients. There is no question about that. And it is particularly a serious issue because a fair proportion of your patients, of patients in inpatient settings, suffer from either primary or secondary types of affective disorders, mood disorders. And the risk of suicide among persons who have some type of mood disorder is estimated to be anywhere from 40 to 60 times higher than it is in the general population. It's way, way up. So while in general it may not be a remarkable and highly significant cause of death, in different environments the meaning of suicide changes, and the reasons for taking different attitudes toward it is connected as much to the nature of that environment as it is to any abstract notion of the value of human life. Recently, I get a newsletter that includes, among other things, recent rulings on state court decisions on different types of actions and activities on the part of mental health professionals, psychiatrists, psychologists, social workers, mental health aides, whatever, against which a family or an individual has brought suit. And in Wisconsin, within the last 3 months, a very significant suit was brought against a psychiatrist who was a staff member of a community inpatient, a short-term inpatient facility, and the hospital, and won on both counts by the family of a man who was a father, a husband, who'd been hospitalized for treatment of a serious mental illness, acute attack of mental illness, and was discharged even though he made a documented statement that if they put him out of the hospital, he was going to put himself out of his misery. And the psychiatrist, according to this report, opposed discharging him. Did have that in his favor, in his support. But the hospital policy, based on the ability to pay for a bed and the absence of any more convincing evidence from the point of view of hospital management than an alleged threat, was not enough to keep the person in the hospital. And 3 days after they left the hospital, they committed suicide. And now the hospital is going to be paying many, many times over what their per diem is because they were found laxed in their responsibility toward this patient. And it will be regarded as a kind of case law precedent that will be brought up over and over again. So really, from the hospital's point of view, what was significant about this suicide is how much it's going to cost them in fines and penalties. Obviously, the attitude they had about the person was made clear by discharging him prematurely against medical advice. What are some basic points about suicide? Now let's kind of bring our thinking into a focus on how do you recognize it? What are some basic attitudes that people have, some mindsets, some of them justified, some not? Well, first of all, as we've indicated, suicide's not easily conceptualized. It's an infrequent event, which means that, among other things, the techniques that have been used to study it in a predictive fashion have been very limited because anything you're studying, when it occurs very infrequently, makes it difficult to analyze in terms of probability models and mathematical models. Most models based on probability mathematics, as used in science, require and assume a fairly large number of cases so that you can look not only at a mean or an average case, but a spread or variance around that mean. And there's simply, suicide isn't that kind of phenomenon. The risk of attempting and or committing suicide varies greatly among persons. Attitudes towards suicide are variable and related to basic value systems. This is something that I have been stressing and will stress even more very shortly. Suicide is an event which results from a complex set of factors. There's no single cause of suicide, and yet you hear people repeatedly say, why did that person commit suicide? And they get a single answer, even from professionals. Oh, because his wife died, or because he was depressed, or because she didn't stay on her medication, whatever. That's not an answer to a question about what caused suicide. It's a part of an answer. Suicide attempts and completed suicides may be basically different types of events. Even though I've said that the best single predictor of a completed suicide is an attempted suicide, among attempted suicides, there is a proportion that are really staged performances. They are done for the purposes of sending out messages and getting attention, and not for the purpose of ending one's life. However, among the false negatives that, among the false positives, the ones who didn't appear to be attempting suicide but succeeded, there are some of these performers who don't know enough anatomy and pharmacology, etc., and they engage in what they think is going to be a relatively safe performance to evoke a response from people around them, and they actually end up killing themselves. I've had, unfortunately, been involved in the treatment of a few persons who fell into that category as well, and they simply didn't understand the chain of biochemical events in their body when they started the process. There are practical limits to suicide prevention. We'll really talk more about that next week than this week, but it's a basic notion and value orientation that many people feel uncomfortable with, but is simply a fact. There is just so much you can do to prevent a suicide, and then any additional effort is truly wasted. It does not increase the chance of preventing that suicide. A few years ago, I was working with a family. The husband, father in the family was in his early 60s. He had suffered a very serious business reversal. They had lived in a very affluent community in Montgomery County in Pennsylvania. The wife decided, apparently sometime before the business failure, but she brought it to a head at the time that the business failed, and the husband was faced with considerable debt, that she was going to discontinue the marriage. The ally that the father had in the family was the oldest daughter, who was very concerned and in some ways psychologically excessively bonded to the father and alienated from the mother, but nonetheless he needed allies of any sort. At that point, he had been hospitalized on 3 different occasions within the previous 18 months because of depression, and 1 suicide attempt and 2 threats. And I became involved in the case at that point. I was not treating the father directly. I was involved in his treatment and working with the daughter and serving as a kind of a counsel. And I advised them that he was a high-risk case and that they should keep him away from any kinds of weapons or instruments that were highly lethal, which they did, and he had been an accomplished outdoorsman and marksman and so forth. But he had the foresight, if you want to call it that, to conceal a weapon from them, and they weren't familiar with how many guns and hunting instruments he had. And within about 3 weeks after they had taken away all of the guns and locked them up and so forth, he found time by himself, and the daughter monitored him all the time she was home and had a neighbor come in and spend time with him. So there was a lot of effort made to prevent this man from committing suicide. and he killed himself with the gun. And this time he knew how to do it. I mean, he ruled out all possible factors that might prevent it from happening, and he killed himself. So there was really a limit to what could be done there. And this was a person who was determined to kill themselves. There are no medications specific to preventing suicides. Very quickly, again, some myths and misconceptions about suicide. People who talk about and threaten suicide don't commit suicide. Absolutely not. Most people who commit suicide have made suicide threats. Any of 10 persons who kill themselves, 8 have given definite warnings of their suicidal intentions. Suicides happen suddenly without warning. That's not true. There are definite prodromal symptoms or indicators that a suicide is developing, and you have to learn to look for those. Suicidal people are intent on dying. Well, this is a debated issue, but in my own experience, I've found that there are persons who definitely are intent on killing themselves, and they will kill themselves. I've also found that there's a category of persons who don't want to die, as I put it. They just want to stop living for a while. Unfortunately, there isn't any way that you can handle that, but it's a way of expressing their meaning and their attitude toward life. They just can't bear to go on living without an interruption, but they would very much like to be revived when they recover themselves. These are tragic cases of people who kill themselves but don't really want to kill themselves. And then there are people who are the performers. They're most frequently found among different types of personality disorders, borderline personality disorders, narcissistic personality disorders, histrionic personality disorders, and they build in suicide as a part of their routine, as a part of their style of being a human being. They're the ones, if you're in private practice, that will either call you or leave messages on your answering service anywhere from midnight to 5 a.m. in the morning, always on weekends, because if they're not having a good time, you're certainly not going to, and they want you to know just how distressed they are with things. And if getting you out of bed at 3:30 in the morning, when I do a callback, when I think it's that serious, I get a sense sometimes if I'm not annoyed enough that the person's not satisfied, so they try to further provoke me on the phone because I wasn't angry enough and upset enough about being awakened. And by the way, I'll mention also that another area that overlaps with suicide that is not to be confused with it, although one has to know how to make the distinction, is self-mutilation. For a long time, people treated self-mutilation as suicide attempts. And self-mutilation, I mean any kind of action to make incisions or scar the body or cause some kind of injury to the body. And we now know, of course, that with a fair number of people who engage in self-mutilation, it isn't suicide at all. In fact, it's one of these paradoxical phenomenon in which they are able to calm themselves and reduce their anxiety and bring themselves into a better sense of contact with reality by inflicting pain on themselves and by self-mutilating aspects. It's really a self-medicating, self-therapeutic intervention on the part of the person who does it without them fully. Some of them understand. I mean, that's a lot of the insights for the cause came from reports, self-reports from patients who say, I just do this because I don't feel as scared and as floating away as I did before I cut my arm or before I stuck the pin or needle into my arm. Self-mutilation is not the same thing as suicide. It's a different phenomenon. It just looks like it on the outside in many ways, and that's why you can't rely simply on observing externals and understand suicide. Well, by now you've probably already had a chance to review the other myths and misconceptions And I would only want to underscore the final one: all suicidal individuals are mentally ill. That's certainly not true, and that's, again, another factor that we have to keep in mind when we talk about attitudes towards suicide, efforts to intervene and prevent, and efforts to treat suicide. I'm going to move now very quickly into the material that I know some of you, again, have heard before, but I've abbreviated it somewhat to give you some sense of historical and cultural differences in attitudes towards suicide. In the 20th century, we have maintained, for the most part, an attitude towards suicide, no matter who is committing the suicide and what their motives and meaning are. We've maintained an attitude and a set of values that was initiated back around 600-700 A.D., at the beginning of the Dark Ages, the early medieval period. And that is that suicide is categorically an unacceptable, undesirable, unjustified, and abnormal behavior. And it was initially, during the early Middle Ages, connected with demonic possession. And then as people converted their thinking about mental illness from demonic possession to a more scientific perspective, it became viewed as pathological behavior. But I put to you very seriously that this may not be the prevailing attitude by the middle of the next century. And indications of this are already clear on several ballots in the November election of '92, the presidential election in several states. Referendum items were put on the ballot for the public to vote on, not because I think anyone really thought they would carry necessarily or that they would clearly lead to law, but to get some sense. They were kind of like surveys, attitude surveys of what the public's view is on suicide at this point. And of course, they were mostly all Western states where we know all of the radical and uncivilized people go to live. Not us East Coasters who know what truth is really all about. And there was a remarkably high positive response in some states to the referendum item that either a person should have the right to request permission to commit suicide, or that in consultation with a physician should be allowed to assist a person in committing suicide. Only they didn't call it suicide, ending their own life. And the reason for this is because one of the ironies of our success in medical technology is that we are able to keep people alive even when the normal meaning of human life and existence no longer applies to them. We can technically keep basic biological functioning going when there is, under any ordinary and even scientific sense of the term, human existence going on any longer. And we're locked into laws and attitudes and values that are over 1,000 years old. Not an issue I think we should deal with recklessly and precipitously. Does require a lot of thought, but it's something we are now beginning to think about. I mean, in 1930, that item would never have made it on the referendum anywhere in the United States. That didn't matter that much because in 1920 and 1930, people were still overcoming the shock of the influenza epidemic in the United States, where more people died overall in the United States and in Europe from that epidemic than died from the bubonic plague, than died from any other epidemic in the known history of mankind. They were between two world wars. Living and dying was not something that most people felt they might be concerned about, living too long or in a way they didn't want to live. That's changing now. So while the issue of suicide and mental illness and the issue of suicide and people who have affective disorders may not change as a function of that, the general attitude of the community is appears to be changing, and it is, I say, ironically, a result of the success that we have had with our medical technology and medical science. I had to say, in all honesty, that I do get a little, I guess, cynical, not even amused in a unusual sort of way every time I see Dr. Kevorkian on television with this little home lab kit that he's developed. It's to me, it's symbolic of the tremendous incongruity that's developing between practice and values when someone who's a trained physician, whatever else people may say about him, he's a trained physician, he had a career as a physician, he's a trained scientist, he's worked with laboratory equipment for years and years, and he comes out with this little kit that looks like something that someone would build in an 8th grade general science class, and talks about this as his technology. I mean, why isn't somebody who develops a Smith & Wesson able to bring that out? So, and if you don't like the Kevorkian technique, then we have this other one here. It's guaranteed to work if you do it this way. There's a kind of a black humor about it that reflects the fact that we are at a position of change in our history and our culture, and it's visible in the way this is presented, the way society's reacting to it, who the key character becomes, the arch enemy in many points of view, the bête noire, the provocateur, this guy who was otherwise a relatively ordinary physician most of his life and is now catapulted into international attention and notoriety because of this very simplistic little mechanism he has that uses very basic biochemical principles to kill people, to help them kill themselves. But the issue, the underlying issue, is a very important one, a very serious one. If we look, for example, at early Greek and Roman cultures, we find that legislation concerning suicide was based wholly on the principle that suicide was considered legal only if it was authorized by the state, or contrariwise, it was considered objectionable or illegal only if it was not authorized by the state. So we have a period of time in which human beings reached a high pitch, point of civilization and culture, and the prevailing attitude was there's nothing intrinsically good or bad about killing yourself, but you may not do this on your own impulse. You have to get permission. You have to get, the state is the only one that has the right to decide ultimately whether you live or die or take your own life. So that in Athens, a man who killed himself without permission from the state was punished for having committed an injustice to the city. That's how it was defined and viewed. The honors of regular burial were denied to this person, and whichever hand was most directly involved in causing the suicide was cut off, severed from the body, and buried separately. Strong censure to the act. But these punishments were applicable only when the person had killed himself without having previously asked permission of the proper authorities. And I said recently when I was talking about this that I keep saying himself and he and so forth through this because even though Greek and Roman civilization reached a high point in human culture, it was not particularly liberating to females, and for all practical purposes, females didn't have any civil rights in Greek and Roman culture, so they couldn't go and apply for the right to commit suicide. It's unmentioned in the literature. I guess they just assumed that women were not interested in committing suicide. Life was such a continuous joy to them, being subservient to the master of the house, that they had no reason to be disillusioned or disappointed or dissatisfied with life. As long as he was okay, they were okay. But these punishments were applicable only when the person killed himself without having had permission. At Athens, for example, if the citizen asked authority of the Senate before killing himself, stating the reasons which made life intolerable to him, and if his request was granted, suicide was considered a legitimate act, and permission was granted. The laws read as follows: whoever no longer wishes to live shall state his reason to the Senate, and after having received permission shall abandon life. If your existence is hateful to you, die. If you're overwhelmed by fate, drink the hemlock. If you are bowed with grief, abandon life. Let the unhappy man recount his misfortune. Let the magistrate supply him with the remedy, and his wretchedness will come to an end. The magistrate, among other things, had a supply of poison, just the right amount. The necessary quantity was given to the approved suicidal candidate, and after having told the council his reasons he had for killing himself, he received permission or did not receive permission to kill himself. Early Roman law was much the same. According to one historian of the time, an emperor or a king called Tarquin the Proud, to combat an epidemic of suicides, ordered the bodies of the dead crucified after torture and left prey to birds and wild beasts. The custom of denying burial to suicides also seems to have persisted into Roman civilization. According to another historian of the time, till a rather late period in Rome, there was an institution similar to the one in Greece that was intended to modify the severity of the laws regarding suicide, and the citizen who wished to kill himself simply had to submit his reasons to the Senate and receive permission. The public conscience, while reproving suicide as a general rule, reserved the right to authorize suicide in certain cases. Such a principle is close kin to that which forms the basis of the institution in Rome that was carried on right to the end of the empire, and was formulated in the statement that there was practically only one cause that was viewed as unacceptable for asking to commit suicide, and that was the wish or the desire to escape the consequences of criminal sentence. You couldn't apply for suicide if you were trying to avoid criminal sentence. Now, again, that might seem amusing in some respects, but there was another major legal case that carried on for several years. It was resolved only this past year in the United States Supreme Court because it was treated as a civil rights issue of a young man who killed all of his family in Louisiana while everyone agreed he was in a state of acute psychosis. He was convicted and sentenced to death, but the law in Louisiana, as it is in most states, does not allow you to execute someone who is insane, as the law puts it, at the moment, and you have to maintain them until they recover sanity. They can't be comatose or unconscious or anything else. They have to be, with all of the, the sense of justice inherent in the law, they have to be fully aware of what's going to happen. You know, they have to go into the gas chamber or be strapped into the electric chair, fully conscious of what is about to happen and why it's being done. So they had a medication that would make this person fairly lucid and non-psychotic, and they were using it, and the state found out about it and said, well, okay, you know, give him a good dose, and we'll take him out the next day and put him in the gas chamber. And the physician involved refused to do it because he said that his Hippocratic oath made him believe that he only used medication to keep people alive and to do as little harm as possible, but he wasn't an agent of the state to sober people up or bring them back to a state of lucidity so that they could then be executed. And this became a very protracted case in law, and the patient refused to use the medication, understandably, and they maintained that in this case they could not require him involuntarily to use the medication. And back and forth, the Supreme Court agreed that that he could not be given the death penalty. He would have to be given a sentence of life in prison. No one questioned his guilt, not even the inmate, but that he could not be executed. So it's another twist in our attitude about life and death and suicide and punishment and homicide and so forth. Not so different from things that people in Greece and Rome thought about. With the decline of the Greek and Roman civilizations, the Dark Ages and the Middle Ages, we see the rise of medieval Christianity in Europe, and suicide was formally forbidden. It was unconditionally unacceptable, which is almost where we're still at, but changing somewhat. And I'm sure for some of you personally, this may reflect your values, your attitude. I'm aware of that, and I'm not about to say anybody's right or wrong, simply that people are different and have been, and we need to keep that in mind if we're going to be treating people who are very different in their experiences and behavior. In 452, for example, the Council of Our Lays declared suicide a crime and claimed that it was caused by a diabolically inspired fury. At the Council of Prague in 563, it was decided that victims of suicide would be honored with no memorial in the holy sacrifice of the Mass, and the singing of psalms should not accompany their bodies to the grave. Civil legislation followed that the lead of canon law or church law, adding material penalties to religious penalties. My first personal experience with suicide, and one that influenced my thinking about it and about other things in life, from that point on, involved a family member, an uncle, paternal uncle. My Uncle Tony, at about 35 years of age, decided to jump off a very high bridge in Scranton, Pennsylvania, and died from the injuries incurred. And when my father and other members of the family went, I was raised in a very traditional Orthodox Irish-American Catholic household family. When they went to see the parish priest about burial, he took out a form and he said, well, here, no problem. You sign here indicating that your brother was temporarily insane, and we'll bury him over in the cemetery with the rest of the family in sacred or blessed ground. And my father said he wasn't crazy. He was not insane. He jumped off the bridge because he was unhappy. His wife left him. His business failed. He was not insane. I'm not going to say my brother was insane. The big argument ensued, and as a result, many years later, 1993, my Uncle Tony's remains are buried in unhallowed ground. I don't know how he feels about it, but the process of decomposition hasn't been much altered. In any case, it was a profound, I'm joking about it a little bit because it was a distant issue with me, but at the time it was a very profound issue in my family. I can't emphasize how much religion meant in that family, and here were people pitted against their religion and their belief system over the issue of whether a person might commit suicide without being insane, and if so, were entitled to what was viewed as a very important experience and ritual, burial from the church in sacred ground. And it tore my family apart. It's not a neutral issue. It's not something you get over. And I lived with discussions about that all the way through my childhood and adolescence. I think people in my family still bear bad feelings about that. Examples of how strong that was in the Middle Ages, the body of the suicide was tried before the authorities in the same manner as cases of homicide of one person by another. And they would bring the corpse into the hearing room and seat them, prop them up, and treat them as if they were being tried in front of their peers. The deceased's property was diverted from the usual heirs and reverted to the state. Many customs didn't stop at confiscation, but prescribed various tortures in addition. For example, quote, at Bordeaux, the corpse was hung by the feet. At Abbeville, it was dragged through the streets on a hurdle. At Lisle, if it was a man, the corpse was hung after being dragged to the crossroads. If a woman, the corpse was burned. Even insanity was not always considered an excuse. And while the intensity of these judgments have declined through the years up into modern time, the same basic principles still prevail. That's the point of change that we are now confronting as a culture and a society. And say very quickly, finally, that not only in the Judeo-Hebrew tradition and the Christian tradition, but in the Islamic tradition, suicide is a totally unacceptable act, and the section from the Quran that's often quoted to justify this is one in which Muhammad says, "Man dies only by the will of God according to the book which fixes the term of his life. When the term has arrived, they cannot delay or hasten it by a single moment," which is part of our problem now. We do delay the time. We have decreed that death shall strike you each in turn, and no one shall anticipate us, meaning God. So that it was definitely an unacceptable act under all major religions, and the reason was that the term of life and death was something that was divinely determined. Again, there's a collision taking place between science and belief systems. Not something people are comfortable talking about necessarily, but that notion that when your number's up doesn't make as much sense now as it did even 50 years ago. And we have to reassess what it means to be human beings, and part of that reassessment process is definitely going to deal with the issue of suicide. Okay, what I'd like to do now is to begin to get into the issue of how professionals interested in the phenomenon of suicide have gone about studying it and identify some of the major methods that have been used and discuss with you the differences in the way in which you collect data and assign meaning to suicide depending on which method you approach. And then we'll move from that into a beginning of a discussion on clinical issues, which we will then spend full time on next week, as I said, even down to the what to do kinds of practical issues. There are basically three major approaches to studying suicide, at least within the last 20 or 30 years. So-called scientific analysis of suicide. One approach studies the characteristics and the symptoms of persons who have either attempted suicide or attempted and committed suicide. Go back, you go through case records, and you select out designated pieces of information on each case, and you look to see if there are any patterns, anything that indicates what these people had in common. The problem with this, as with all retrospective techniques, is that it doesn't really establish cause and effect. At most, it may show a kind of an association or a correlation, but it hasn't really yielded what it promises to yield, which is some strong predictive cause and effect approach to identifying suicide. Nevertheless, for obvious reasons, ethical ones not the least withstanding, it's a little difficult to use a traditional classical experimental design in studying suicide where you randomly select subjects and then put some of them who have perhaps made threats or had ideation of suicide in one group called the experimental group and others in a control group and do something and then see if there's a difference in the suicide rate. And that we haven't progressed that far in terms of revising our attitudes towards suicide. So that the logic that would be necessary to really draw conclusions of a scientific nature about causes of suicide are different from and limited compared to other types of phenomena that we study, especially in biological sciences. Nevertheless, these studies have generated quite a number of checklists, suicide detection or prediction scales, and I don't mean to suggest that the information is worthless by any means. It has helped to provide some methods for doing a much more effective job of identifying people at risk and giving some forewarning and allowing some opportunity to take preventive steps to reduce that risk. For example, a representative study of the characteristics and symptoms genre from Hospital and Community Psychiatry, 1988, by Drs. Dingham and McGlasson, looked at a sample of 403 persons who had been treated at an inpatient unit called Chestnut Lodge, and it examined these folks ten years after they were discharged. A table here that would be helpful to look at. What Table 1, rates of suicidal intent, conveys to us about their data is that all of the persons who were in the one group of 68 had had an expressed suicidal intent at admission to the hospital. In the other group, subjects had never expressed any suicidal intent or made any suicidal attempts. Of the subgroup with suicidal intent, after 10 years, 15 of the 68, or 22%, had actually committed suicide. Of those who had no expressed suicidal intent, 21 cases had committed suicide, but that represented only 6% of that group, so that the difference that's important for our purposes is between the 22% and the 6%, or an almost 4 times larger incidence of completed suicide among persons who had an expressed intent of committing suicide on admission compared to those that did not. And in addition to recognizing from this information that intent expressed at admission or as a part of intake data is an important thing to be aware of and to pay attention to, the second focus was placed on symptoms, because Digham had also been interested in investigating the claims that certain types of conditions, I'm sorry, I said symptoms, I mean diagnoses. Certain types of conditions or diagnoses were much more likely to result in successful suicide than others. And when he combined intent with diagnosis, he produced Table 2, which shows us that if you look at a diagnosis like schizophrenia, among all of the patients, the 403 cases in the total study, 18 were diagnosed as schizophrenic. That represented 12% of all patients. But when you looked at those who committed suicide, it represented 22% of all patients, or a kind of doubling. And if you look at something like borderline personality disorder, there were 68 patients. 68 patients. Of those who had expressed some suicidal intent, there were 17, or 25% of that group. But when you get down to those that actually committed suicide, it's only 6%. So there's a great reduction in actual versus threatened suicide for borderline personality disorder. But the group that clearly bears most attention and watching is the bipolar affective disorder group. They represented 19 of the total patients. Only two of the subgroup with suicidal intent, or 11%, but 50%, or half of the cases with bipolar affective disorder committed suicide. So there's a tremendous increase there. Now, part of that's an artifact of small numbers, but even if the numbers were larger, I've seen in other studies you get that same kind of effect. So with borderline personality, you get a lot of talk about suicide and intent and threat, but when it comes to actual carrying it out, it drops down to much lower frequency. With bipolar affective disorder, There may even be a reduced amount of discussion about it by the patient, but of completed suicides, clearly they're at much higher risk. And finally, he wanted to look at how suicidal intent and actual suicide combined with diagnosis and some other variables, and that's the final table here that we can take a look at. As you can see that in subgroup A, those who had no intent of suicide, 53% were female. Of the subgroup who expressed expressed no intent those who had expressed no intent and did not commit suicide, 53% were female. Of those who expressed intent but did not commit suicide, 68% were female. And of those who expressed an intent and committed suicide, it drops down to 34. And the reverse is true for males. The risk of committing suicide, in other words, independent of expressed intent, is much greater for males than for females. A history of identity disturbance is much greater among those who committed suicide than of those who expressed intent but did not commit suicide, which is 43%, or those who had no intent or no suicide, which is 53%. So that there are variations in the risk of suicide attached to these factors, such as history of identity disturbance, history of impulsivity, history of manipulative suicide threat, history of self-mutilation. You can see there, of those that expressed intent but did not commit suicide, self-mutilation was up to 65%, but of those that actually committed suicide, it dropped down to 16%. So that self-mutilation, as shocking as it is not a particularly strong indicator of the likelihood of a completed suicide. The outcome of all of these predictive analyses relating characteristics to expressed intent and actual suicide has been the production of checklists and different evaluation scales that have a very practical clinical use, although one has to bear in mind that they're anything but foolproof, but they do allow one to begin to get an initial focus and give a rating to someone in terms of suicide risk. Now, next week we'll go over in detail a set of scales that can be scored. It's intended to assess with a specific final global score the risk of a person committing suicide in a inpatient unit. One version of the scale is administered by a clinician. The other is administered to a family member so that you can compare your impression with the family member's impression, and both scores allow you to place the patient in some risk level for suicide. But in a less specific and elegant way, even these simple checklists provide us with some information. For example, depression or mania is one of the symptoms and indicators of possible suicide attempt. Social withdrawal or self-induced isolation, suicidal ideation or morbid preoccupation with death. People who are at risk of committing suicide don't necessarily have to spell it out as such. They can become interested in talking about other people that have died, or what happens, what's the point of living? You just grow old and die. There are any number of ways in which they can signal through this morbid preoccupation with death that the issue of suicide is beginning to develop for them. sudden departures from routines and indifference to completing tasks, reference to other persons' suicides, anniversary dates as stressful events, I find to be very significant and something well worth watching. This is another thing that seems to be very much a human phenomenon. In fact, as again, some of you may know because you are a member of Jewish religion or you know of it, that the tradition in Judaism is to place the headstone at someone's grave only after 12 months has elapsed from the death of the person, because the 12-month cycle is a ritual and symbolic indication of a year of life, a start, an end, and a beginning again. And we live out our lives in 12-month units, and it takes 12 months to grieve and disengage ourselves from someone who's died so that they are fully dead, not just physically, but emotionally. We've disengaged from them. And the ritual at that point is saying, now it's final, is to place the headstone. This is something that's been recognized for a long, long time and put into ritual form. Others of us who don't have that built into our religion or ethnic culture may not recognize the significance of anniversary dates quite so much. But even in general medicine, for couples that have been married for a long time, 30, 40-year marriages, and one spouse dies, especially if it's a fairly sudden death, the first 12 months after that death, the risk of the other spouse dying, even developing pathology that was undiagnosed or perhaps not even present before the other spouse's death, goes up precipitously. That's the time that the family doctor, the family, and everybody else should keep an eye on this person, because the risk of death during that first 12 months up to the anniversary date, the closer you get to that anniversary date, goes up. Once that 12 months is over, statistically, the risks begin to drop, and the person has, in effect, seemingly said, however they've said it to themselves, I'm going to go on living. This was tragic. One phase of my life is over, but I'm not ready to die. And then the risk drops off again. And it's one of these aspects of science that you can't give a full explanation for, but on the other hand, you can't deny the actuarial figures, the statistics. And I've been involved in cases where I've advised family members to be very careful about watching the other spouse, and they have. It wasn't always suicide, but the person died. They just withdrew. They changed their eating habits, their sleeping habits, etc. They seemed to get ready to die, and within 12 months, there was a second death. The anniversary dates are something to watch. If you have that kind of information in a record with a patient, be aware of it. Notice and be prepared to look for symptoms, anxiety, depression, withdrawal, as they approach the anniversary date of their admission to the hospital, of a divorce, of the death of a spouse or a child or a significant other. This is information that you can use, and it has surprising value and accuracy in heading off a suicide. The dissociative manner, another indicator, extended, controlled, intense anger, someone who you see is getting angry a lot but is not externalizing it and is holding on to the anger for an extended period of time. Hallucinatory messages with reference to death. I mean, the classic paranoid schizophrenic is probably the person we associate most with this, but it occurs in other conditions, and if the reference to death is to oneself or to oneself and other, first I have to kill two people and then myself, obviously this is something that one needs to look at very closely. And provocative acts or high-risk activity is another indicator. Now, these kinds of symptoms can also be broken down into differential rates or significance by age groups and two basic breakdowns. You can be seen here. By the way, I've pulled these I'm in the process of pulling these together with some other information and having it printed up and duplicated. And if any of you are interested, as some of you were the last time in having some of this, I'll be glad to send a basic copy to Mrs. Cohen, and then she can let you know that it's available if it's of any use to you, any value to you. With children, I've got adults up there first, right? Okay. With adults, risk factors that are related to suicide. Attempted suicide is related to substance abuse problem. That's probably another one of the high significant variables. Recent stressful life event. Being a female, attempted suicide is much higher among females than it is among males. Completed suicide is much higher among males than among females. Current psychiatric disorder, low lethal method, ingesting mildly toxic substances or low dosages of medications that could be lethal but not a great amount. Manipulative or passive-aggressive personality, living alone, history of impulsivity, marginal social life, and low self-esteem. Completed suicides, the order changes a bit and some other factors become involved. Previous attempts, most significant. Substance abuse problem. When you have previous attempts and substance abuse problems and a young adult male all combined, that in itself ought to make you very, very observant and concerned about this person. Add to it an affective disorder, and you've got a very high-risk case. So these variables by themselves don't necessarily signify anything, but in combinations become very useful ways of identifying high-risk cases. Hospitalized for psychiatric care, recent stressful life event, high lethal method, male Caucasian, living alone, unemployed, separated, divorced, or widowed. Among children and adolescents, slightly different set of indicators occur, although some of them are the same. My reflexes are starting to go after 2 hours. I can't get the slide focused. Among attempted suicide, recent stressful life event, substance abuse problem, borderline or other personality disorder, female, low lethal method, marginal social life, high achiever, low self-esteem. This is not a frequent phenomenon among children and adolescents, but I've found in my own experience when you do encounter it, it's one that you want to watch. What I mean and what's meant by a high achiever, low self-esteem, is the patient who, when you look at their objective record, school performance, IQ score, athletic ability, etc., they're well above average. They've distinguished themselves in school, but they have terribly low self-esteem, and it creates a tremendous psychological pressure for them because no matter how well they perform, they can never feel as though they've done well enough. So they're kind of like the Greek character Sisyphus. He keeps pushing this huge rock up a hill, and just when they think they've reached the point where they've satisfied the world, whether it's their parents or their peers or their school principal or whomever, the damned rock starts to roll down to the bottom of the hill again, and they just sort of... And when you see that in a child or an adolescent, that's a good reason to try to get some contact with them and be concerned about suicide. I can fully understand it. The motto that, maybe this is a good place to kind of conclude and then leave a few minutes for questions or comments for this week's session. The inscription over the entrance to the Inferno or hell in Dante Alighieri's Divine Comedy says in Latin, but translated into English, "Abandon all hope, ye who enter here. And I remember when I read that as an adult and had spent some time working with patients and been trained in psychopathology, especially depressive disorders, it struck me that Dante either had some experience with depressive disorder or knew someone who did, because nothing really gets to the core of what is the agony and the pathology of serious depressive disorder than the experience and the sense of hopelessness. And nothing seems to be more potentially destructive to human beings than the sense of hopelessness. People can put up with remarkable adversity. People can put up with remarkable pain and discomfort. Recently, on one of these 60-minute shows or something, I saw a short piece on a fellow that is quadriplegic. He's a cartoonist named Callahan. I had admired his humor, his cartoons and magazines. I hadn't realized that since he had been a young man, he's now, I guess, in his early 40s, he'd been confined to a wheelchair. He has very little motor control in his hands, but he does draw the cartoons. And his whole life was radically changed by this accident, this senseless, unpredictable accident that put him in these circumstances. He's intelligent, sensitive, etc. And he's alive, and he gives every indication of wanting to stay alive as long as he can. People undergo all kinds of pain and discomfort when they know there's a way out, when they know there's some escape from their despair. But what happens, as many of you may know, when people develop acute depressive disorders, affective disorders, what they will tell you if you are talking to them is, this is never going to change, is it? I'm always going to be like this. Now, fortunately, we can tell them with some validity that in a fair number of cases that's not true. It may be episodic, but it's not going to always be like that, and you will feel better and work with us, and you'll feel a lot better. But the sense, the phenomenological experience of depression is the despair of hopelessness, and the high achievement, low self-esteem adolescent or child in middle school is the experience of hopelessness. I'll never get out of here. I'll roll this rock up the hill forever, and it'll always roll back down. And somebody will always say, well, you could have done a better job. Or worse, even if they say, wonderful, you can achieve, you can handle achievement. You can't handle failure. Implicitly or explicitly, ironically, the parents become so protective of this special child that the message that gets across to them is that their excellence is of very little value in protecting them from the real threats of life. They can't handle failure. All their friends can handle failure. They see it going on all the time. I mean, they watch their friends go through it, but there's something wrong with them. They can't handle failure. They can only handle achievement. It has just the opposite effect that is intended by people who give them this message. It doesn't make them more alert or more improve their judgment. It gives them a sense of helplessness and hopelessness. So this is a big factor. Manipulative intent, school-related problems, and living away from parents. Again, I will make these available. I don't see a need to read through the remaining ones. Just want to provide the closure that I talked about. What we've looked at this time is the broad picture, the background. We now recognize suicide's not a simple event. It's something that has to be viewed in different ways, in different situations. And I want to close very, very quickly by sharing with you an actual suicide note which shows why suicide notes themselves are not the best source of information on motive. This was found scrawled on a bathroom mirror in a room where a woman had committed suicide. Dear Bill, I'm about to kill myself. I hate you and I hate my life. Love, Janet. There's a paradox in the message for me, at least. I hate you, I hate my life. Love. Thanks very much.